So now we'll hear from Dr. Laura Staunton, and she'll tell us about the effect of surgery on T cell function in patients with early stage lung cancer.
Hello everybody, thank you very much. It's an honour to be here. My name is Laura Staunton. I'm doing an MD currently in the Trinity St James Cancer Institute in thoracic surgery. And the title of my talk will be Exploring the Effect of Surgery on T cell function in patients with early stage lung cancer. Okay, so these are my disclosures. I think the bottom one is probably the most important for the difficult questions later on. So going through the cancer immunity cycle, so initially there's an immune-mediated destruction. Following this, after chronic antigen exposure, there's different levels of and different ways that T cells can be disrupted. This includes energy, exhaustion, and senescence. And the T cells then become impaired to respond to activation. For surgery as well, it triggers systemic inflammation and immunosuppression and provides a window for metastasis or disease progression. So we wanted to look at different immune biomarkers on the surface of T cells, inhibitory receptors, as well as co-stimulatory receptor, CD28. The reason why we wanted to look at both of those is that they're incorporating into the immune checkpoint, the immune checkpoint inhibitors are incorporating into the standard of care for perioperative setting. PD-1 and CTLA-4 currently in use, and LAG-3 and TIM-3 are in preclinical trials. So I will be looking at the immune receptors on the surface of T cells at 3 different time points. So it's a longitudinal study. So the time points are the preoperative blood, again at first follow-up, which is 2 to 4 days, and then at 6 to 9 weeks, which we call second follow-up. And these have all been cryopreserved in liquid nitrogen, the peripheral blood mononuclear cells, and we have a plasma biobank as well. The clinical pathological characteristics, so I've analysed half of my cohort so far, 21 patients, and I have the rest still to do. Bear in mind that's 120 samples altogether that I will have for the N equals 40 because of the 3 time points. So I analysed these at via flow cytometry. I'm not sure if anyone has used flow cytometry, but the picture at the top is often how it feels like. I've also then quantified them with FlowJo and then done a number of different statistical analysis. So far we've only 5 controls, but in the next few weeks we plan on collecting a lot more. So if you look at the third column there, you can see that the percentage frequency of PD-1 on the baseline samples, the median percent frequency, and then you can see on CD4, CD8, and NKT cells, and this increases throughout the 3 different time points, which is statistically significant, and you can see this on our graphs here as well. It's also worth noting that the control levels were higher than the baseline, however, this wasn't statistically significant. So TIM-3 and then co-inhibition. So co-inhibition is multiple receptors on the surface of T cells. So I've looked at TIM-3 and PD-1 in all of the T cell types, and then TIM-3 as well. So similar, you can see there's an increase throughout the 3 time points. Same with CTLA-4 and LAG-3. This was statistically significant in CD4 cells only. And again, with CTLA-4, you can see that there's can be up to a 5-fold increase in some patients at the second follow-up time point. CD28 then is our T cell enhancer. This was reduced in our controls, then increased at the baseline, and then started to reduce down throughout the different time points. And you can see this here by the graphs as well. So our T cells postoperatively shifting towards dysfunction. This is something that we wanted to look at just from the receptor point of view. There's a lot of different ways that we would need to look at it through functional assays, genetic assays. Certainly we could see that the inhibitory receptors are higher in the controls, and then the CD28 are lower, and then the inhibitory receptors increase throughout the time points, and the stimulatory receptor reduces. Why potentially potentially, is this happening? It could be because the ctDNA and the CTCs are being released, or maybe it's just after surgery. We do have a club project, which is a liquid biopsy project in Ireland, that is looking at ctDNA and CTCs in the same cohort, so we'll be able to correlate these findings to see if there's anything significant there. The fact that the controls are higher for the inhibitory receptors could be different reasons when I was kind of looking through literature. One of them is that the tumor infiltrating lymphocytes are higher in the tumor immune microenvironment than they are in the peripheral cells. And also when T cells become exposed to the antigen, initially the inhibitory markers increase, and then the co-effector cells that are being produced don't have the inhibitory receptors. This is just the workflow of our liquid biopsy project. So we're looking at EVs, ctDNA, CTCs, and immune cells. So future work, I'm going to complete the rest of the controls as well as look at the levels of chemokines, cytokines, and immune checkpoint proteins in the plasma and correlate these findings with our post-op complications and survival analysis. So it's very much in its infancy, and we're only about kind of 10 months in for our survival analysis at the minute, so it's too early to tell. So in conclusion, lung cancer surgery leads to an increase in inhibitory receptors that I've spoken about there, a downregulation of co-stimulatory receptor CD28. These could potentially be used to guide the timing for adjuvant immunotherapy treatment and to identify patients that are most likely to benefit. So I'd just like to thank all of the laboratory. One of my colleagues sent this lovely gift to me this morning, and I'd also really like to thank all the patients who consented to be part of the study. Thank you very much.
Congratulations, beautiful work. Are there any questions? I'll ask one. Any correlation between what's going on in the plasma and the tumor? Do you plan to look at that?
Exactly, yes. So we're going to look at that as part of a multiplex assay. So we're going to look at cytokines, chemokines, and immune checkpoint proteins. So it's basically an ELISA assay. So we'll be doing that over the next few weeks.
Excellent.
Dr. Spicer has a question.
When you do look in the tissue, do you have the time at which the tissue was resected? and are you
any time?
Are you only looking at ELISA, or are you doing some sort of multiplex molecular imaging on the tissue?
So we plan on doing a multiplex on the plasma, and then the tissue was looked at separately in a different part of a project.
Just to say that when we did, so on the paper we published using imaging mass cytometry multiplex of stage 1, we've subsequently looked at the time of resection, and looked at the immune composition of the tumor immune microenvironment, and the fascinating finding is that the linear, sort of the dynamic diurnal curves that you expect to see in mouse and humans in blood are reproduced based on the time at which the tissue was resected. So just as a control, perhaps you may want to take into consideration the time at which the tumor was resected so you're not confounding any kind of relationships between what you're seeing in the blood down the road to just a spurious, well, this was resected in the afternoon versus the morning.
Okay, perfect, yeah.
And also, if I may, so my friend Jennifer Wargo has a beautiful paper, so she's a melanoma surgeon, on the ONCEF that you gave at the induction that altered the gut microbiome, and she says that post-operative, it leads to immunosuppressive states. So this is what you might see. I don't know if in your center or a surgeon, I assume you gave ONCEF before the incision. But you'll see Jennifer's paper might change the perspective you think of prophylactic antibiotic.
That's why we wanted to do the 3 different time points as well, to do kind of immediately after surgery as well as 6 to 9 weeks to see if there's any differences.
Great.
Great, thank you.